Welcome back. This is the Neuro Health broadcast, and I am your host, Dr. Joseph Kappas. Today we are joined by our guest, Dr. Jess Lofgren of the Brain and Body Co. in Carmel, Indiana. Today, Dr. Jess is going to talk to us about the different subtypes of concussion, because believe it or not, no concussion is the same. So these subtypes help us to categorize what symptoms and findings that patients tend to fall in. And no, you do not have to necessarily fall into only one category. So this was a great episode where she breaks it all down, gives us a really thorough understanding of concussion, the different nuances that go into it, how to test concussion, and then also how to rehab concussion. So I think a lot of you are going to really enjoy this. So if you or anyone you know is suffering from the long-term effects of concussion, definitely send this their way or give it a listen. And after a quick word from our sponsor, Dr. Jess Lofgren with the Subtypes of Concussion. This podcast is brought to you by Delta Neuro Health, located in Columbus, Ohio, where non-invasive, personalized care is revolutionizing the way we approach complex neurological issues. With cutting-edge techniques in functional neurology, functional medicine, and chiropractic care, we're leading the way in managing conditions like concussion, dizziness, brain fog, anxiety, POTS, attention, and more. To learn more, visit our website at deltaneurohealth.com. Hey everyone, welcome back to the show. Today we are joined by Dr. Jess Lofgren of Brain and Body Co. Thank you for joining us today.
Thank you for having me.
Yeah. So you are not too far from us. You're just our neighbor estate over in Indiana.
Yeah, yep.
So
Right next door.
yeah, enjoying all this beautiful weather this time of year.
Oh yeah, I mean I really love the gloominess. It's great.
Oh yeah. Oh yeah.
That West weather.
It's just the greatest. But Dr. Jess, I was hoping I guess the topic that we're talking about today is going to be concussion subtypes and categorization of concussion. Before we get into that, can you let our audience members know a little bit about yourself and why you got so interested in concussion in the first place?
Sure, yeah. I would say my beginning in the functional neurology world was when I was in chiropractic school. So I went to Palmer down in Daytona Beach. So definitely different than
A little
Midwestern.
different.
A little different. But I was going through courses and I was in I think I was in my fourth quarter. So getting towards the end of my first year. And we had a speaker come in, I believe it was Dr. Garcia came in, and he came in to talk about the neurology behind an adjustment. And at that time, I was sort of trying to understand everything that we were doing in a chiropractic realm and trying to make sense of things that I weren't quite getting the answers that I was looking for. And so I went to this talk. One of my friends convinced me to go. I wasn't really, at the time, not really thinking much of it. And I was hooked. I mean, the second I did it, I was completely hooked on it. And so the rest of my time in chiropractic school, it almost felt more like I was going to school at the Carrick Institute and sort of doing chiropractic school on the side. I really dove in deep while I was a student. And at that same time, I was really involved with doing CrossFit and different sports like that. And so I was just starting the Carrick Institute when I was at a CrossFit workout. I had been learning about concussions, been learning about different mechanisms of injury. And I was in the middle of a workout. I was on the floor. I don't know, doing like ab mat sit-ups or something. I don't know. And then I went to get up and I was on time. So trying to do it as fast as I can. And when I came up, I hit the back of my head on the barbell, full force. The weight was completely weighted down. So no momentum, no movement of the bar, just my head. And everything went black. And next thing I knew, I woke up and I was like, not woke up, but came back to it. I was on the bench and people were around me like, hey, are you fine? And me not being, being the stubborn person I am, I finished my workout. Now I obviously know that probably was not the best thing, but so at the time that was all I had. And then as things started to progress, I started noticing these symptoms that I hadn't had before. My migraines have gotten progressively worse to almost daily. I was smelling things that weren't there. It was at the time where I was in an anatomy lab. And so I was smelling the formaldehyde for days later. And it was just like a constant trigger smell. I felt dizzy all the time. I just didn't feel like myself. Conversations were extremely difficult. I just like could not make eye contact with people. It was just so hard for me I felt rude because I couldn't maintain a conversation. Now I know it's because I had an oculomotor. I was in that category. And so I had a really hard time just maintaining my gaze on anything. And so I had all these things going on. And at the same time, I was doing the Carrick Institute courses and I wasn't quite making the connection. I was just like, something's going off and I know it's neurological symptoms. And then finally it was that I'm having persistent post-concussion syndrome. And so when that happened, I started getting functional neurology care myself. So I was out of the learner seat and into the patient seat. And I can say now I don't have migraines anymore. I have minimal neck pain here and there, don't have issues with eye contact. So it really did change my life and made me more passionate about going down the concussion route instead of, just going more from a broad perspective to that post-concussion world.
Mm-hmm. And that's probably, you said you stepped out of that learner world and into the patient world. And I think being that patient and experiencing what it's like for yourself is like the final lesson, right? Like
right.
That's what solidifies
it. Gives you it gives you like a different empathy for it because, when you're learning it, you're so clinical about it. And, you're like, okay, this functions this part of the brain and we check it by this. But then when you're the patient and you're getting it done on you, it's just a completely different experience. And so it almost gives you more empathy and more being in their shoes when you're working with them.
Mm-hmm. Yeah, which makes you a more well-rounded and just an overall better clinician, I think, when patients are able to connect with you like that.
Yeah, I agree.
So you said you fell into the ocular motor category of concussion. People listening to this may or may not be familiar with concussion and the symptoms and what can happen after one. But now we're talking about different types of concussion, and people are like, well, what is going on with that? So I guess, can we just first start by defining the different types of concussion?
Definitely. Yeah. So when we look at concussion, in the past, we've divided it into 7 subcategories, is what we call that. And a subcategory is pretty much, it's just a cluster of symptoms that make up a specific area or category. And so traditionally we would divide it into 7, but recently the concussion and sport guidelines, they adopted a new way of dividing these and identifying them. And they are now into 5 different subtypes with 2 associated symptoms syndromes that can be with it. And so the reason that they're divided like this is because with a concussion, it's not just if you have a concussion, you hit this one part of your brain, right? There's so many different areas that can be damaged and affected after having a concussion. And there's so many pathways in the brain that it's hard to classify a concussion as just this X amount of symptoms. Or these specific symptoms. So the categories sort of give us an idea of, okay, what areas of the brain might be more affected than others, and where do we need to negate our treatment, or where do we need to focus our treatment on with that patient? So like I said, there's 5 categories and 2 syndromes. The 5 categories are migraine and autonomics, affective, so like your mood, cognition, ocular motor, and then vestibular function. And so we'll go into what each of those mean if you want to go through that. Mm-hmm. And then the syndromes that are associated with it are sleep and somatic. So somatic is like your neck pain. And so when we look at those, it's not like you only have ocular motor, right? there's a ton of overlap in there. And so you can get more of an idea of like, okay, they have ocular motor. I said I had difficulty with eye contact, and then I was having daily migraines. So I fit more into that ocular motor migraine, and then probably some stuff with vestibular as well, right? And so there's a lot of overlap there. It's not like one person's in one category. It just gives us a better idea of where we want to focus our attention.
Yeah, and that was actually something I wanted to bring up or ask is, even though we have all these different categories, is there some is it like more of like a Venn diagram or more of a box? And it seems like it's more of a Venn diagram, right? Yeah, where
It's
there's a lot of
definitely
the
more of a Venn diagram. And I think there actually is one in an article. I can try to find it for you to link to this podcast, but
Mhm,
it's just a colorful, like looks like a flower with all of
mhm.
them overlapping because there is just so much overlap between the symptoms.
Yeah.
It's just like if you're working with a neurology patient, you can say like, I'm stimulating the left parietal lobe, but we know there's overlap with everything. You can't really precisely isolate one area. You're always going to get some networks that are involved. Same thing with syndromes. And that's the
Mhm.
reason why.
Right. And I think that's why when we're dealing with brain injury and concussion, why the treatment approach has to be so individualized and specific, and the assessment has to be so in depth, because you cannot just have a protocol for that's going to cover all of these things. And also, if you did have a protocol that covered all of these things, you'd be overemphasizing things that didn't need to be emphasized, and then possibly underemphasizing things that really needed to be emphasized. So I think
Yeah.
that's where functional neurology really shines.
Yeah. I mean, it's definitely, I don't think I've done the same thing on any of my patients ever. There's no way to create a protocol. That'd be nice and be great for us, but then we
Mhm,
become more of like a technician, right? And
mhm,
so there really is a lot that we need to understand, not only with working with concussion, but understanding how the nervous system functions on its own. Because if we were to say, I created the best concussion protocol in the world, if you have a concussion, we're going to take you through these 5 steps and you're going to feel great. That's not realistic because what if I have someone who has ocular motor issues and then they have vestibular pathology and I'm making them do optokinetics and it's killing and it's crashing them, right? For
mhm.
one person, that might be great, but for the other person, it might send them the opposite direction.
Yeah.
And so it's really important that if you're a patient and you're suffering from persistent post-concussion syndromes, that you're looking for someone who understands that it's not a protocol, it's not like a step by step, like it has to be individualized and it has to be extensive.
Hmm. And even to take it a step further, if we even identified, if we did the minimum and just identified which subcategories somebody fell into, you can't even have a protocol for just each subcategory, because if you have someone with a
Yeah,
vestibular deficit, it's the treatment's going to look totally different. I mean, for every patient,
right.
one vestibular injury is not the same as another vestibular injury. So it's like you said, it really has to be individualized.
Yeah,
Um,
100%.
and then
Yeah.
piggybacking off of vestibular, can we kind of go into maybe some of the common symptoms or complaints that patients might experience within each category?
Each one? Yeah, sure. So let's start at the top. So we'll start with migraine and autonomic. So I like to say autonomics are sort of like your foundation. Okay. So if we don't have good autonomic integrity, which is just something that's taught at the Carrick Institute, so it's nothing I created myself, right? It's something that we're taught there. But if we don't have a good foundation to build our house on, where cognition would be the top of our house, our roof, then everything's going to fall, right? So we always start by looking at autonomics first, make sure we have a stable foundation before we start adding those extra, I would say, like icing on the cake, right? For your nervous system function. So if someone has a subtype of a migraine autonomic, the most common symptom is obviously going to be that they have a headache, right? And if it's in a migraine category, they're going to have an aura associated with it or not. And then they have associated light and sound sensitivity. Some of those people might have nausea and dizziness with that as well. And then as far as the autonomic side, those people can have a host of different symptoms. I mean, it's hard to say, they're going to have this, because the autonomic nervous system controls it. everything, right? Like it plays a role in everything. And so this person might have difficulty standing up too quickly, where their heart rate races, or they feel like their vision goes dark for a minute, or they feel dizzy. They might have warm, sweaty hands. They might have cold, sweaty hands. They could have digestive upset. They could all of a sudden have issues with their hormones, where maybe their menstrual cycle is now off compared to where it was before. We can fine tune that out in our exam. And there's also self-reported assessments, like the Compass 31 is an assessment that we might use for autonomic. It's just a series of 31 questions that are related to autonomic function. And the patient goes through and self-reports if they are experiencing any of those. So that's what we generally look at with the migraine autonomic. Now, when they come into our clinic, it's a whole different thing that we're looking at, right? We want to check that Compass 31. We want to check autonomic testing. So checking O2 sat, heart rate, blood pressure in all three positions, seated, lying down, standing up. We might do a tilt table test, so where they start laying down and we bring them slowly up and see where that heart rate changes. We might do the hand grip test, which is a newer one for me, a few years new for me, but essentially you have them squeeze a hand dynamometer 30% of their max, and then you're checking their blood pressure on their opposite arm for 3 minutes time, and then checking pupil light reflex too. So all of these different assessments are going to give us an idea of where their autonomics are sitting. And obviously I'm missing a lot of other factors that we could test, but we could be here all day doing that, but we're not going to do that today.
Exactly.
So there's just so much in the autonomic category, but I think that gives a general idea of that one. That would be the most in that one.
Right. And yeah, we could list things all day long, but I think that, like you said, gives a good picture of what's going on. And
we could do this whole talk on autonomics. Yeah.
That's right. Yeah. But I'm glad you started with autonomics, because like you said, that's the foundation, that's the building blocks of the rest of what you're going to do next. Because if you don't have proper blood flow to the brain and body, then everything else you're doing is kind of fighting against upstream, so to speak. So
right, it's just an uphill battle. I mean, you won't be able to get in and do what you need to do if they don't have the proper blood flow getting to the areas you're stimulating. So autonomic, step one for sure. So then let's talk about the next category. So the next category I would jump into would be vestibular. So this is, the inner ear is going into central vestibular. Most concussion patients or post-concussion, they're going to be dealing with more central vestibular issues than peripheral, which would be like your BPPV kind of things. But these people, they're going to have dizziness, they're going to have lightheadedness, nausea, vertigo, disequilibrium, or they're going to be off balance. They might complain of difficulty with visual motion in front of them. So like if they're back in practice and they're running a play and they see the stands and the people moving off to their side, that might really throw them off. And then they could have some issues with losing their balance, or their gait might be off as well. So those are kind of things we're looking for in the vestibular world. There's different ways that we can test that. We can look at the vestibular reflex, which is essentially seeing that the eyes are moving opposite of the head. We can look and see if they have visual motion sensitivity, and we can look at their ability to have conjugate gaze. So are they able to focus both eyes equally on a target? And then looking at convergence, accommodation. Well, that's more in the oculomotor surgery, but we're going to be looking more at, are they able to do this vestibular ocular in that visual fixation, or are they having issues with visual motion in front of them?
Right. And depending on which of those things they're having issues with, or maybe the direction that they're having issues with, is going to completely structure and determine your treatment strategy.
Yeah, definitely. So depending on what area is affected in the vestibular system, so say their left central vestibular processing system is firing more than their right side, I'm not going to want to do stuff turning them to the left and firing off the left more and making a larger discrepancy, right? I'm going to want to target trying to equal out that side to side. And now that's really important if it's a sports related concussion too, because if I have an athlete with a vestibular issue after a concussion and they turn one direction and they're fine on the field, but then they turn the opposite direction and everything is off. Now, what's their chances of having a re-injury, you know?
Right.
And so
Exactly.
now we're looking at, okay, is this player going to be affected and have a higher chance of re-injury? And the obvious answer is yes, they are. So that's why we want to make sure that we are checking these kind of things and make sure that they're able to turn both directions without having these vestibular things show up.
And I think mentioning that discrepancy is so important, because even if, going back to if you had a protocol for a vestibular injury, chances are you're going to be turning the head in both directions. So if one side needs it more than the other, you're just going to increase both the input to both sides. That discrepancy or that difference is still going to be there. So people are still going to feel off. So yeah.
Right. It's still there. So if I just give someone a popsicle stick and tell them just to do this all day, I'm not really fixing the discrepancy. Like you said, I'm just going like that with it. So that's why we want to make sure that we're assessing in the way that we talk about in the neurology world.
Exactly.
Yeah.
What is and then you had started to mention some of the oculomotor testing too, which is the next category, because those kind of go hand in hand with vestibular a lot of times. But yeah.
They do, they go so hand in hand. And so it's easy to mesh them together. I mean, there are obviously some eye movements that are more vestibular focused than others, if we can even say that. So like the vestibular ocular is obviously a more heavy on the vestibular side, but yep. So after vestibular, I'd be looking at ocular, motor, or visual. And these kind of people, I would say this is a really common subtype for the persistent concussion people to have. At least in my practice, I see this a lot. And these kind of people, they're going to have issues with focusing their eyes. They're going to have issues with learning. So if they're trying to visually process information, they might have a hard time obtaining that information and understanding and processing what's coming into their world. And then they might just have like this feeling of just this visual perception issue. So this is sort of like what I was talking about. I was having where my eyes weren't able to fixate on a target, especially up close. So a convergence mechanism. And so whenever I was close face to face with someone one-on-one, it was really hard for me to maintain that. And I would almost lose my train of thought because my brain was so focused on trying to maintain eye contact that all of those higher order things like cognition and affect just went out the window, right? So that's why I put that on the next step on the pyramid, and why the Kerrigan Institute talks about it in that order as well. And so these kind of people, we can do a VNG assessment. So if you have the goggles where you can measure their eye movement and see the track on there, that's awesome. Don't need it, but it's definitely beneficial for the patient to see it on a camera. You can also do this bedside. So if you are just getting into functional neurology, or maybe you don't have that kind of equipment, you can assess all of these eye movements on bedside using your thumb or finger. And so essentially what we're looking for saccades, so jumping of eye movements from one side to the other. We're going to be looking at pursuit mechanisms. So is it a nice pursuit? We'll be checking convergence, divergence, accommodation. And then we're also going to be checking if they're able to fixate, like so fixation, gaze, near, far, side to side as well. So there are different areas of the brain involved with each of those eye movements. So that's where it's like, again, we can't make a protocol because just a patient I had this morning, if I gave her a convergence, just following in pursuit mechanism, made her feel awful. If I gave her a saccade, so with some rock speeds coming in, terrible. But if I came in using a side to side, a horizontal pursuit with the convergence, it felt amazing to her, right? So this is why a protocol is not going to work. And now, will I ever do that again with a patient? Who knows? But that's why it's so individualized, because you can't just tell someone, okay, we're going to just practice going saccades back and forth, and then you're going to follow targets back and forth, and you're going to be done for the day. Right. So that's another step on that, making things personal for the person.
Exactly. It seems like, or it is, where you have to have a foundational knowledge of neurology and how systems work together, how networks work together. And then once you have that foundational knowledge, then you can apply the artistry of kind of what we do, right? Like you said, this
Yeah.
theoretically should have worked, the saccadic convergence, but it didn't for
Yeah.
that patient. So you had to get creative. You had to kind of use your artistic side to help that patient out, which yeah,
Right.
that's why our jobs are safe from AI, I think.
I think we're safe. Yeah. And I think that's something important too for people if students are listening or if they're just starting out in the functional neurology world, that don't get so in the weeds about
Mhm.
if it's X, do Y, because there is such a huge creative side to it. And so when I first started, I started out with Dr. Mark Ellis. I was working under him, and he always got so, I'm so like, I want the pictures drawn perfectly. Like I want to know step A, B, C, D. And I would come to him and I'd be like, okay, I see this. I think it's this part of the brain. I think it's this. And he'd be like, okay, so are their pursuits not working well? Okay, fix their pursuits. What's another way you can make a pursuit happen? And so he took me out of the try to think everything so academically and make it an art. And that really helped me get to another step with my patients. It wasn't no longer, okay, I see a problem with this, I'm going to do this. It's now like this art of how can we make this work best for the patient. And so I think that's an important thing for students and people starting off with functional neurology. Get the basics, but then don't be afraid to be creative with it.
Hmm. Exactly, because every patient's going to respond differently, and you could have bulletproof, quote unquote, bulletproof plan, and none of it works, and you have to
Yep.
go back to
Or it
ground
makes them worse.
zero.
And then you're just like,
Yeah,
now what?
yeah,
So yeah,
exactly.
definitely being willing to change your direction and accommodate for that person.
Hmm. And while you were while we were talking about kind of the different categories so far, one thing, and I don't want to get ahead of myself, but one thing that I was thinking is a lot of patients will have one category that is kind of the cause of another category, right? And I think you mentioned this a little bit too with the eye movements and the affect being related, and but then you could also have a vestibular imbalance that's causing autonomic issues. So it
Yeah.
gets a little circular. Um, but how, as a clinician, do you try to tease out the most important thing and then go from there?
Yeah. So the first thing I do is the symptom scores. That just gives me like a baseline idea of, okay, what's affecting them the most, right? And so that's before I even get them in front of me, I can get an idea of, okay, what's actually affecting their daily life right now. So that sort of gets me starting to focus. But then when I'm doing my exam, I'm looking for different areas that are causing either an exacerbation of their symptoms greater, right? Or I'm looking for something that improves stuff that I'm seeing on my exam. So I always make autonomics and vestibular my number one priority just because it's the foundation. But then if I'm seeing that this issue with ocular motor is contributing to the lower part of the pontomedular area, which also has vestibular input, right? I might do a little bit more focus on that ocular motor area to get some more feedback into that lower part of the brainstem to hopefully affect the central integration of the vestibular system without having to directly hit the vestibular system, right?
Mhm.
And so there's it's hard to answer that question because it's almost like you're just sort of like you get in there and you're in front of them and you're just doing it. You know what I
Mhm.
mean? And you're just sort of finding what's going to make the most sense, and you're playing this game of clue where you're looking for, okay, midbrain on the right with the faulty frontal lobe inhibition. Like you're looking for
Mhm.
this game of clue, and then once you find like where all the common variables meet, then that's the area you're going to focus on, right? And
Mhm.
so, and then you just sort of see like a cascade of effects once you find that spot you want to really focus.
Mhm. Yeah, and then that again goes back to the artistry and kind of the experience that you just have to have from seeing lots of people. What are the last two categories or subcategories, I should say?
Yeah, so the last two are more at the top of our pyramid, right? So this
Hmm.
is the kind of stuff that makes us human. And so these categories are the affective, which is our mood, and then cognitive. So
Hmm.
that's our ability to essentially our performance, right? And so we'll start with affective. So affective is mood related symptoms. So they could have increased anxiety, increased depression. They could be feeling more emotional. They could be feeling more on edge, maybe overwhelmed. They could be more irritable, loss of energy. I mean, anything that you can think of related to mood is going to fall into that category. And
Hmm.
one thing that Dr. Antonucci says that really resonates with me for this kind of, for all of them really, but this too, is that you get out of a concussion what you bring into it. So if I had anxiety before I had a concussion, chances are that I'm going to get out of the concussion what I brought in. I'm probably going to have increase in my anxiety symptoms after the concussion because I already had anxiety before. And
Hmm.
then the concussion just sort of exacerbates that and increases that.
Hmm.
So those are different things we can look at self-reported scales. So the positive and negative affect scale, and then quality of life symptom ratings. And this is a good avenue to start co-managing with other practitioners, so other counselors, therapists, people where they can work through these changes in moods, because a lot of time if an athlete has a concussion and they're out for the season, that can affect their mood to start with as well. And so it could affect their ability to heal because maybe they feel like they're never going to get back to where they were. It can affect their trajectory moving forward. So having that ability to identify that on the front end, and one, give that person hope that we can make changes, and two, give them the strategies that they need to make the changes if they need more assistance in that area. So that's, I wouldn't say that that's my area of focus or our area of focus as a functional neurologist, but it is important. It's our responsibility to identify it if we're working with persistent post concussion
Hmm.
and send them to the appropriate people if needed.
Right. Because we can cover a lot of these bases with our therapy approach, but we're
Yeah.
not always, we sometimes have to co-manage, right? And we have to
Right.
give people who are experts in that field their due and let them uh yeah, do what they do
Yeah.
best. We do what we do
And listen,
best.
I am all about co-management.
Mhm.
I do not have the functional medicine side yet. And so I know that there are some times where I want to send people there. I know there are some times I want to send people over to counseling. And there are some times where I need other management people. So I mean, there it would be naive of us to say that we could fix everything and that,
Mhm.
we're the healers of all. We have our lane, and we have this incredible ability to make the changes that we can make.
Mhm.
But there's also times where we need to sort of set our ego aside and find the appropriate thing for that person too.
Right.
And so that's in that effective category. That's usually where I'm thinking like, okay, where can I send this person? And as an owner of a company and as like the clinician here, I need to start building sources of different personalities and different counselors, because it's not just
Mhm.
a send them here. You also want to find someone that you feel like that person's going to mesh well with and relate to. So that's why you need to have more than just one person that
True.
you're working.
Yeah, just like every therapy doesn't apply to everyone, not every practitioner,
Right.
I guess, applies to everyone. So, yeah,
Right.
especially
And
when you're looking
now,
at affect.
right. And now
Mhm.
caveat here is that we can make changes to effect. I don't
Mhm.
want to dismiss that completely, right? Like our therapies and stuff can obviously have an effect
Mhm.
on someone's mood and behavior. Um, but just sometimes we just want to add in a little bit extra.
Mhm.
But that does not mean to say that we are unable to do that, because we very much are able to affect their mood with our therapies.
Exactly.
Yep.
Yep. Exactly. And then I think there's one more then.
One more, and that's the top of the top. So this is the performance, the high achievers. This is the cognition side of everything. And so I and so when we put cognition on the top, it's because it's essentially it's not necessarily needed for survival, but it's
Hmm.
for thriving, right? So it's at the top of the list. And when these people fall into this cognitive subtype, we're looking at issues with attention, reaction timing, speed of processing and performance. So maybe they're not able to run the play the way they used to run the play, right? Or maybe they're having their test scores are all of a sudden not where they used to be. They're having a harder time retaining information in order to do well on their test.
Hmm.
Um, and then I was going along with that, changes in memory, storage and retrieval of memory, and then just issues with organization of thoughts and behavior. So this person might all of a sudden be sort of all over the place. They have a hard time really organizing like what tasks they want to get done, what they're trying to articulate to somebody. It's just really that higher order being. And
Hmm.
so if we're in a sports performance world, I know I'm in Carmel, Indiana, and I have Grand Park in Westfield, which is my neighboring town. And it's a huge sports place here. And so people are all about performance here. They want to be the highest performer that they can. And so there are different ways that we assess that.
Yeah. So cognition is obviously very important. It's what makes us who we are as humans. So it might be surprising for someone to find out that a concussion can actually affect this. And I think a question that I get asked a lot by especially youth athletes who have sustained multiple concussions, um, especially if they've sustained multiple concussions before making their way to you, is the question, do I keep playing? You know, I'm never going to be in the NHL or the NFL, but I love playing hockey, football, whatever it is. But this is my sixth, 10th concussion. Uh, what do I do? Right. So how do you
Yeah.
have that conversation with someone?
It's sort of like this double-edged sword. Now, if they come in and they've had, like you said, like 6 or 10 concussions, and they're just at a point where it's like, oh my gosh, like you have all this stuff going on, and like you're barely getting through school at this point because of all the effects that you've had post-concussion, maybe we'd be more weary about getting them back on the field. And so it sort of is it depends on the kid that I'm seeing and what we're finding and how it's going to affect them in the bigger picture. But going along with that too, concussion is, yes, we always talk about concussion in sport, but the sport related concussion is such a small percentage of the total amount of concussions per year. I think it's almost upwards. Last study I saw was like 60% of concussions are from falls, traumas related to like domestic abuse and accidents, like motor vehicle accident kind of things, right? And only a small percentage, I think it was 30%, please don't quote me on that, but a smaller percentage was actually related to sport. And then if we go even further into that, they did a study with my alma mater, Virginia Tech. They looked at number of hits per practice and in game per season, and how many concussions resulted in, or how many impacts resulted in a concussion. The numbers were like 1 in 4,000 hits actually result in a concussion. And so you also want to play into that too. Like, so the people that are like, don't put your kids in sports, don't let them do that. It's a 1 in 4,000 chance that a head impact is going to result in a concussion. But what is the result if they're not involved in a sport and they're not doing something they're passionate about? And so that's sort of where you
Mhm.
come out of the doctor hat and you're looking more at that person as a whole and their lifestyle outside of it.
Hmm. Yeah, I
I hope that
think,
answered your
no, definitely.
question.
Yeah.
Okay.
And I think just like rehab strategies, your at home lifestyle strategies have to be a case by case basis too. There's no one right answer for everyone. But I think the common denominator for anyone in that situation is make sure your brain is working to its best ability to rehab you uh, to as close to pre-injury level as possible, and then B, to try to prevent the chances of re-injury, right? So I think at the
Right.
end of the day, that's what it's got to come down to. But then obviously, yeah, like you said, case by case basis, really taking that whole person into account is important.
Right. And there are different ways that we can assess if they're ready to go back into sports. So that's a different conversation, right? Like, I mean, we don't want to just throw them back in full team practice, like full gear, go. That's not going to be the goal, right? We want to gradually work them up and monitor their symptoms as we return them back to play. So doing stuff like the concussion buffalo treadmill test, right? To decide where we want their aerobic fitness level to be at, making sure that when they're doing their sport, that their symptoms aren't going up 2 points on a 10-point scale, and that their symptoms aren't lasting greater than an hour, right? So we want to make sure that we're not just being like, oh yeah, just go ahead, go back on the field, right? We want to make sure that we're appropriately gauging the steps to get them back in there fully.
Exactly.
And if we do those steps correctly, we should be lowering and minimizing the chance of re-injury for that athlete.
Exactly. Well said. Well, I think we have two more points to discuss, right?
We have two more. And so these aren't necessarily subtypes. So what they found was these used to be in the subtype category, but October of last year, this concussion sports group, they adopted this and turned them now into more syndromes, because they are more symptoms that coexist with post-concussion, but they're not exactly caused by concussion. So those two are sleep as well as somatic, which somatic is you think cervical or your neck. And so there are different ways that we can assess this. Sleep, there's again a self-reported, the Pittsburgh Sleep Quality Index, which is just they fill out how their sleep is. That gives us an idea of where they are with their sleep. And then cervical, that's where manual practitioners can thrive, is that we're looking for faulty errors in their neck, whether that be joint proprioception, whether that be cervical sprain strain, decreased range of motion, stiffness, anything like that, weakness in their upper extremities. That's where we can really come in and do that manual therapy to address that side of it.
Yeah, exactly. Which I think leaves a lot of these categories just perfectly set up to be dealt with by somebody who practices functional neurology, because we check a lot of these boxes. So I don't know. Can you think of anywhere else you would rather go for a concussion?
That's a hard question. I don't want to make anyone mad. No, I definitely think functional neurologists, we are definitely geared with the most like so much training, so many tools in order to really help these athletes, or not even athletes, just anyone suffering after a concussion, those persistent concussion syndromes. So anyone who is, we call it concussion literate, who has had the training, understands the subtypes, and isn't trying to just put you through a protocol, is going to be, your best bet when you're seeking some symptom relief.
Absolutely. So we have been talking for a pretty decent amount of time, so I don't want to take up too much more of your time, Dr. Lofgren, but could you maybe give folks who are listening just a final piece of advice, or something they can take away with, especially those who might be suffering with post-concussion syndrome right now?
Yeah. So if you're suffering from post-concussion syndrome or symptoms related to post-concussion, the number one thing I would say is to not wait or ignore the symptoms that you have, right? The longer you wait, that doesn't mean we can't make changes, but your outcomes are going to be far greater the sooner you seek care than if you wait longer. Now, if you've had a concussion years ago and you are like, I didn't even know this existed, I didn't know that I could find relief, that doesn't mean that your ability to heal is expired. It's not expired. It just might take a little bit more effort, a little bit more precision, and a little bit more time, right? And so I don't ever want anyone who's suffered from a concussion to feel discouraged or feel like that's their normal, because that's not always the case. There are things that we can do, and there are doctors like you and me who are spending hours upon hours studying this stuff understanding it to the ability that we can to help these people and get these people back to the lives that they've been living in the past.
Yeah. I'd say 99 out of 100 patients who come in who say they've tried everything have not been to a functional neurologist yet. Um, so definitely hope out there, and there's always somebody who is going to approach things differently that can help you. So yeah, beautifully said. And where can listeners find more about you? Where can they follow you? Tell us a little bit about your clinic.
Yeah, so my clinic is located in Carmel, Indiana. It's called Brain and Body Co. So the website is hellobrainandbodyco.com. You can also follow me on social media. I like to share a lot about concussion, all the updated information that's been coming out, and different strategies that you can use both at home and in a clinic setting. My Instagram is at the Brain and Body Doc, and then my clinic is at Brain and Body Co. So I would say the Brain and Body Doc, probably I share a little bit more for clinicians as well. So if you are a clinician or a student, that would be the direction you'd want to go.
Perfect. Yeah, you share excellent content. I love your page, so definitely give her a follow. But I want to thank you again for coming on today. This was thorough. This was informative. This was fun too, as fun as concussion can be.
I thought it was a great time.
Yeah. So I think our listeners are gonna just love listening to this. So thank you again, Dr. Lofgren. This was great.
Yeah, thank you so much for having me. Always a fan of your podcast. So thank you again for having me on here today.
Yeah, of course. Well, from your host, take care.